The three protective layers of the brain that are basically covering it from all the traumas and the violent atmospheres are the dura mater, the arachnoid mater, and the pia mater. So basically we are dealing with these three membranes and how they can be damaged, what kind of trauma can occur to them that is going to consequently have an impact on the brain as well. So in this lecture, in this section, basically, we'll be dealing, first of all, with the forensic anatomy. As I've already told you, there are basically three layers that are covering the brain and protecting it. That is a physiological thing that God has given, and basically, it's the pia, the arachnoid, and the dura collectively that is providing the protection to the brain structures. Now, the extradural hemorrhage and the heat hematomas. So, what are the consequences of this extradural hemorrhage? How is it caused? Trauma can be one of the cause, but obviously there are a lot of other causes as well. It can be some sort of a birth defect. For example, a lot of aneurysms can lead to these kind of hemorrhages, as well as a lot of blood disorders, and blood dyscrasias can also result in these sort of extradural hemorrhages, and heat hematomas that will be discussed in detail in the related slides and sections. Now, the subdural hemorrhages are the mainstay over here. They're also very important. Again, trauma is the foremost cause over here that is causing these subdural hemorrhages. Infections, blood dyscrasias, and some sort of birth defects can again contribute to these sort of subdural hemorrhages. Then we have the hematomas. Hematomas can be heat hematomas as well, and as on the other hand, it can be something traumatic that is causing these hematomas. So in this slide, basically, it is focusing on, as I was telling you, these are the arachnoid granulations in the mass of the villi, indenting the skull. And then we have the dura. This is another protective layer over here. Then we have the arachnoid, and then we have the pia. So these are the basically three layers that is basically taking the protection part of the brain. All of the other structures can be a part of the trauma. For example, the falx cerebri can be traumatized in cases of traumas, road traffic accidents, whatever the case may be. It can be an inferior sagittal sinuses. The skin is another protective layer, and that is present almost on all of the body. So we're not counting that right over here. So there is some sort of connective tissue, then we have the aponeurosis, the loose areolar tissue is over there, and then we have the pericranium. So these are basically the outer structures. They are also providing the traumatic, they are also providing the protection of some sort, and injury to these can be caused by some sort of superficial trauma. That can be caused as a result of brush abrasions, for example. It can be caused by the use of the blunt weapons, more importantly. And these three layers, as we were discussing, these are the particular specific layers that are designed to protect the brain. So they are the layers that we're going to discuss, the brain membranes. They are called on a larger scale. They're called the brain membranes. So you have to remember that it is the dura, the arachnoid, and the pia. That is what we are talking about right now in relation to the brain and its structures. So the extradural hemorrhage, bleeding between the inner surface of the skull and the dura mater. It is basically the mainstay to the requirement of the extradural hemorrhages. What basically happens here is, it is the usual site in the unilateral, in the peritotemporal area that is more prone to these extradural hemorrhages. Now, it can be caused by a rupture of the branch of the middle meningeal artery. It can be the case in this sense of trauma, and it is basically the posterior branch which is commonly involved in cases of trauma. Now, regarding the clinical signs that it can manifest in cases of the extradural hemorrhage, what kind of clinical symptoms that you will accompany if the patient is alive, of course. We are talking about the medico-legal aspects in the live patients, of course. We're not dealing with the autopsy reports right now. So the lucid or the latent interval, it is again very important. Now, what is basically the lucid interval? It is basically the time interval between the time the person was hit or the trauma was manifested, and the time of the symptoms, the time that the symptoms appear. So it is basically the time interval that takes for the symptoms to appear. It is known as a lucent or the latent interval. Obviously, after the trauma, the effects were there. For example, extradural hemorrhages or subarachnoid hemorrhages are there, but they'll not manifest right after the trauma. They're going to take some time to manifest themselves, and this time interval in which the patient is symptom free, it is known as the lucid interval. So again, there is a raised intracranial pressure. So these can be the clinical signs that is going to indicate that there is some sort of hemorrhage. Obviously, we are going to again move upon, for example, we are going to rely on the CT scan and the MRI reports for the substantial reports. And whenever we're going to write down that there is a subarachnoid hemorrhage or there is an extradural hemorrhage, we have to have sufficient proof to write it down or to diagnose it. The relapse into the unconsciousness is basically also a clinical sign, which is also part and parcel of this extradural hemorrhage. Comma. Lastly, comma is the symptom that is going to appear and is basically the last signs of the extradural hemorrhages that are going to manifest like this comatose patient. So we are not going to let the patient go into this comatose state, and we are going to manifest some treatment modalities so that he may not go into some sort of serious condition. Now moving on to the heat hematomas. Heat hematomas again are basically we dealt with the burned scalps and the burned skulls while we were dealing with the burnt injuries in a lecture that I had already given. When head is exposed to severe external heat sufficient to burn the scalp or the skull, the blood may be extruded from the diplos and the venous tissues into the extradural space to produce a heat hematoma. So this is very important, that basically the venous sinuses are the more prone sites where the blood can extravasate, and basically it can lie over there and cause the hematomas finally. The mechanism that it basically involves is, it can be an obscure mechanism. For example, heat can cause all of these hematomas. Blood being boiled from the diploic layer of the bone through the emissary veins. So it's also very important. And the shrinkage of the brain aspirate blood from the skull. So it's again very important. Now, false hematomas. It can be basically they're brown, friable, adjacent brain shows the hardening and the discoloration from the heat. So they are basically the characteristics of the false hematomas over here. Now, talking about the subdural hemorrhages. Now, bleeding beneath the dura is very important over here whenever we are talking about the subdural hemorrhages. It's basically an area which is lying under the dura method. It was one of the protective layers, and now we are going to talk about any blood extravasation in this subdural space. Now, the lesions are most importantly acute, subacute, and chronic. So these are basically the three phases in which we can subdivide them. The major causes of the fatal child abuse. So child abuse is one of the cause. It can be some sort of a domestic abuse as well. For example, the marital abuse, or which is also known as the dowry abuse in the Asian or in the Indian continent. So it is basically all of these things can be a part of this subdural hemorrhage, and we have to suspect them whenever we see something like that in a CT scan or in an MRI. This is again another CT which is showing the acute subdural hemorrhage. It is a common sequel to any substantial head injury basically. And the causes most importantly are the tone communicating veins and the shear stresses in the upper layers of the cerebrum. They're also very important, and we have to focus on them whether there are any stresses over that particular area or not. The lesions are often pure, and there's some sort of scalp bruising as well. That is basically the bruising is basically going to indicate towards the internal hemorrhages, the acute, whether it is the subacute, subdural hemorrhage or the arachnoid. There is going to be some sort of bruising on the outer surface as well. Now, dealing with the chronic subdural hematomas. The chronic subdural hematomas has its own causes basically. As shown in this diagram, it's basically the arachnoid matter over here, and then we have this collection within the membranes. It's basically the fluid collection between these membranes, and then we have the dura matter. So you can see the space between them and is causing this sort of image in the CT. Now the contents are thick, but they are fluid in liquid and in the liquid shape, and they have areas of redder, more recent bleeding. The loculation is common within the different colored fluids, and underlying brain will be depressed if the hematoma is large and often stained brown or yellow after the altered hemoglobin levels. Now, the neurological abnormality in the old people can also be a cause to the chronic hematomas, and they're not concluded as the cause of. Even if you find them on the CT scans, you're not going to write them on the table that this was the cause of death, because they can have a chronic state. It's a chronic state, and the person was still living with these hematomas, so it is basically not the primary cause of death over here. The large chronic hematomas press the cerebral hemispheres to dent and distort the surface. Now, the dating of the subdural hemorrhages, how long whether it is acute, subacute, and chronic. How are we going to diagnose that just by seeing the CT? So, if the time interval is like 24 hours, the dural surface will have a thin fibrin layer, and the arachnoid surface will have a thin fibrin layer as well. Now, after about 2 to 3 days, there will be sparse mononuclear cells in the fibrin, and there will be rare mononuclear cells in the fibrin as well. Now, after about 4 to 5 days, the sparse fibroblasts are rare, and there are rare hemosidrophages as well found in the dural surface. In the arachnoid surface, there will be rare fibroblasts after 4 to 5 days. Now, after 5 to 10 days, the changes will be like 3 to 5 fibroblast layer neovascularization, that is, new vessels are being formed. There is some sort of a repair process going on, and the capillaries, and there will be sparse hemosidrophages. On the other hand, the arachnoid surface will have the rare hemosidrophages and the sparse fibroblasts. Now, regarding the changes around 10 to 20 days, there will be 10 to 20 fibroblast layers, prominent capillaries, and some hemosidrophages. On the other hand, the arachnoid surface will have 10 to 28 days, 2 to 4 fibroblast layers, and no capillaries are seen in this arachnoid surface. Around 28 days, the collagenization and fibrous membrane formation is marked, and around months to years, the fibrous membrane, the inner surface, is less than half the thickness of the outer membrane. So it's basically getting more thinner day by day. So these are basically the changes that are going to state whether it is an acute, subacute, or chronic hematomas. So in this section, basically, we dealt with the brain membranes, how are they traumatized, and how are we going to classify them into acute, chronic, and the subacute phases. That was the end of this section. Thank you for watching sqadia.com.